Good morning, everybody. We'll continue our cases discussion right from where we stopped last time. And we had an X-ray with an area of consolidation. All right? It's evident on the right field of the lung. And we said that this is, in this particular case, it's a sign of pneumonia with the classical definition of this disease, which means that the inflammatory exudate has filled all the alveolar spaces. So this is the area of consolidation. There is no air left in the alveoli, and an inflammatory exudate has accumulated within the place where air was supposed to be. So now let's see that on a macroscopic view. Which part of the lung do you think is the pathological part? Which part of these two parts? Which is the normal lung that you have learned in anatomy, and which is the part of the lung that is abnormal? What do you think? The upper one or the lower one? Which is the normal? Which is the abnormal? If you cannot make the discrimination, that's no problem. No problem, because that's why I'm here, to help you learn. So don't feel stressed if you don't know the answer. There's no problem at all. But it's my work to explain this. So who can tell me what he thinks? Because you've seen the lung in anatomy, the normal lung. What's close to what you have seen? What's close to what you have seen? Yes. The upper is normal. Yes, so these are, and what are these spaces here? You see these lumen here. You see? What are they? What are these lumen there? The airways. And which part of the airways? The bronchi. These are the bronchi, and we have the surrounding alveoli. All right? Good. What is the difference now? The difference in the lower part, this is a lobar pneumonia. That means that the inflammatory exudate has entered the alveoli. And where did it come from? Where did it come from? It came from the capillaries, from the septa between the alveoli, because this is the microvasculature, which is filled with blood from the right ventricle of the heart, and we have the gas exchange there. So, since there was an infectious agent and caused damage in this environment, inflammatory process has started. That means we have more blood going there to take care of the damage, and the capillaries become congested. But the next step in the inflammatory process is exudation. So white blood cells leave the blood and enter the tissues. And in this particular case, what are the tissues? The places where air should be. So the inflammation started for good to eliminate the stressful stimulus, the microbe, the virus, but it caused problem, because since the alveoli are filled with the inflammatory exudate, what do you expect that the patient has? He has a large part of his lung, a whole lobe, because this is lobar pneumonia. What else could it be? It could be somehow dispersed around bronchi. That means the inflammatory would fill the wall of the bronchi and the surrounding alveoli. That would be bronchopneumonia. This is not the case. Here we have the inflammatory infiltrate within the alveoli, and a whole lobe of the lung has been influenced by this process. So this will, what symptoms will this give to the patient? What do you think? What do you expect based on this macroscopic image? If the inflammation persists, yes.
Difficulty breathing.
It will be dyspnea, yes, difficulty in breathing. And if the inflammatory infiltrate is not moved away, is not taken away so that the lung returns to its previous state of function, then we'll have problems in the blood oxygenation. That means the partial pressure of oxygen will become low and some degree of hypoxia will occur in the patient. So this is very important, and in order that all inflammatory infiltrate is removed by the inflammatory cells, that's the white blood cells who come out of the vessels and are called inflammatory cells, which is the prerequisite, what is it necessary so that pneumonia is lysed. That means we have the inflammation lysis. What is the prerequisite for such a such a good evolution? That the architecture of the tissues in the lung has not been destroyed. Because if inflammation destroys the architecture of the lung, what will happen in the field of inflammation next? For example, think that the microbes are so strong that, and their toxins are so strong that they destroy the neutrophils that go there to phagocytose them. Where do the neutrophils enzyme go? In the local environment. And they lyse the tissue, and this is liquefractive necrosis. So this is a distraction, and if you have this distraction, that's no longer reversible. And what can be in this area of liquefactive necrosis, we'll see next. And what else? If the inflammatory infiltrate persists, apart from neutrophils, what are the other cells that will come next to phagocytose? What are the other cells? Macrophages. If the presence of macrophages takes too long, what will they secrete? They'll secrete fibrogenic factors. And what will happen in this area? Fibrosis. This is also, to a great extent, an irreversible lesion. So we must help the patient to eliminate all these possibilities of distraction in the tissue. That's why, what do we give to him? What do we give the patients to treat this pneumonia? Of course, we have to pay attention to the signs and define the cause of pneumonia, because we have to give medicine, all right? Antibiotics, which will be most effective in eliminating which infectious agents, which infectious agents are properly eliminated by the antibiotics. What do you think? Will they have something to do in viruses? No. Will they have something to do in fungi? No. So, bacteriums. And are there any signs that this is a pneumonia of bacterial etiopathogenesis? What if the inflammatory infiltrate reaches some bronchi and enters in their lumen, what will we find in the sputum of the patients? What will their sputum look like? If we have bacteria, so bacteria bring a large number of neutrophils, so what color will this productive cough, what color will the sputum get? Yes, that's right. It will be yellow to green, because this will be pus. And of course, if we make a cytological specimen of the sputum, we'll see large numbers of neutrophils. So these are signs of bacterial pneumonia. So you can see, you can study which are the most common causes of lobar pneumonia, where a whole lobe is out of function due to the inflammatory infiltrate. So this is a case of pneumonia. You can see bronchi, not particularly inflamed. However, the peripheral airways, the alveoli, are consolidated. Here is another X-ray that we see all these two large infiltrates, which may be attributed to pneumonia, as you can see. However, we can see this is a cavity has been formed. And how do you understand that it is a cavity? What is in the center of the lesion? And it looks dark. Air, it's air. So what can this be? This is not a pre-existing cavity, but it was formed because of the inflammatory infiltrate. What can this be? Necrosis. Yes, like we said, if it was a bacterial pneumonia, a large number of neutrophils would go there, and some of them will be distracted by the toxins of the microbe. Their enzymes would go out, and they could make liquefactive necrosis, such as happens in bacterial infection. So, what is then the process? There is the central part of the cavity, which is filled with pus, and then we have a zone of neutrophils that we can see their nuclei, because within the pus we just see nuclear dust. That means destroyed parts of the nuclei, not whole nuclei. They are not viable neutrophils, those that are there in the pus, in the cavity. Then we'll have a zone of viable neutrophils, and what is the reparation tissue that will be formed to limit this process and not give access. For example, it could give access to the pleura. So the inflammatory infiltrate would fill the pleural cavity, and we could see the neutrophils there. And what is the process? Which tissue is formed? Is fibrous tissue, and this makes the cavity, and this is the abscess as a complication of a bacterial pneumonia. And the problem is, now that the abscess is well formed, as shown in this CT, how can we remove this formation there? How can we treat it? If you give medicine, it goes till the fibrous tissue, because this is the vascularized area. Because you'll give antibiotics, either per os or you'll inject. In any case, they'll reach this area by blood. If the center of the cavity is not vascularized, the antibiotics won't get there. They will stay at the periphery with the fibrous tissue where some capillaries are. So what is the treatment? If we have a well-organized, not forming, a well-organized abscess, what is the treatment? What is the treatment? Yes?
Excision.
You'll have it surgically removed. Of course, if it's in a place where you can feel it, for example, like on the teeth, there is an abscess, you can cut it and drain the pus and give antibiotics, of course, because you do not want reinfection. But if it is in the brain, if it is within the lung, the only way is the surgical excision. Yes?
Why don't we just leave it there? What problem do we
Yes, it is a possibility. If all the whole lesions nearby are repaired, you can leave it, and in the course of healing, the fibrous tissue will predominate, and then there will be no longer a danger of this being a source of dissemination in the blood, because it may cause problems if it finds access to the blood and all these microbes go in the blood. And this will be a cold abscess. In this case, that you judge that there is no problem leaving it there, and reinforcing the immune system of the patient, because theoretically you leave the microbes within the cavity. So it is a source of reinfection. But in some cases you may leave it and follow the patient and see that it becomes a scar, slowly. But the first thing you think is whether you should remove it surgically.
So the abscess will eventually be filled with scar tissue?
Yes, it will predominate, yes. But if you have to judge what is better, watch it, and it has to do with the condition of the patient. There are many parameters. But you think, when you see an abscess, you think that either you open it and drain the pus, so you send the microbes away from the patient, or you remove it surgically. If it is an area where you can easily get, you just cut it and you have the drain of the pus. If it is in an organ deep inside, you think of surgical excision. So that was the abscess formation, liquefactive necrosis. And you see that pneumonia can look like all these extensive infiltrates as well. So that could start as a viral pneumonia. However, since we see that an abscess has formed, virus is not the causative factor for abscess. The causative factor is bacteria for abscess formation. So it may have started as a viral pneumonia. However, during the course of the viral pneumonia, another infectious factor superimposed the case, and we have another factor of inflammation as well, and this should be a bacterium. This justifies the formation of the abscess. So the progression of the bacterial process has led to the abscess formation. This can also happen. Now, here there is an extensive consolidation, an area of consolidation in this lung. And of course, this would be compatible, this macroscopic finding here, this cavity, could be compatible of an abscess formation, like the previous case. And you see that it is from a young man who underwent therapy for acute myelogenous leukemia, and he had a stem cell transplant, and he reached the lowest level of neutropenia. And of course, why did this happen? Why did this patient who had a transplant for leukemia had all these neutrophils in the blood so low that this made him vulnerable to microbes? Why did this happen? What do you think? Yes, please. Of course. So since he had a transplant, you should prevent the immune system, make the immune system not destroy the rejection, not to reject the transplant. That's why he had immunosuppression therapy, and his blood cells, white blood cells, were affected. They were low. And this patient developed a fever and progressive and intractable dyspnea, and you gave antibiotics. Why weren't they efficient? Why were they not enough to destroy the causative agent of the inflammatory process within the lung parenchyma? Yes?
Because in immunocompromised individuals.
He was immunocompromised. That means you give the antibiotics, but some degree of innate immunity should remain in the patient. Otherwise, the antibiotics will not function, will not be sufficient to treat this this infectious disease. And in such patients, you see, yes, this is how diffuse the consolidation is. Almost the whole lung has been affected, and there is hemorrhage, as you can see, and nucleotiding with abscess formation. And here you can look at the microbes involved, and Klebsiella is most commonly related to extensive liquefactive necrosis and abscess formation. It is an infectious agent most closely related to abscess formation. So, and we have all these liquefactive necrosis being expanded. And another very interesting factor is aspergillus, which invades the vascular walls and causes thrombosis. And in these cases, the necrosis is not of the liquefactive type, that means pus due to bacteria, but is of the coagulative type, of the ischemic type. Why? Because aspergillus has entered the vessels, and the vessels were thrombosed, so the tissue who took blood from this vessel is necrotic, has necrosis, not of the liquefactive, but of the coagulative type. Yes, please.
Can you please explain again how this patient got diffuse consolidation?
Yes, he was immunocompromised, so he could not treat the disease from his immune cells. You gave the antibiotics, but they were not enough, because you have to have some cells to treat the stressful stimulus of inflammation. Antibiotics are not enough. And this, it has to do with the phase of therapy that this occurred. This happened when his neutrophils were at the lowest level. Of course, as a result of the treatment, the immunosuppressive treatment he took, so as not to reject the transplant. Yes?
Can I ask something relevant?
Yes, of course.
Would this be considered a professional mistake, or?
No, there was nothing else you could do. But in this particular patient, it caused all this destructive process, which it was irreversible. Because if the whole lung is destroyed, what is there to do? If it becomes necrotic, of course, this is not very common, but it can happen. So when you treat such patients, you should always take into account the degree of their innate immunity, so as to treat these harmful stimuli, the microbes in this case. Here is another infectious agent. You see, like what all these macrophages are filled with, their cytoplasm. This is from the bone marrow of the patient. However, it can become dispersed in the lung as well, and this factor is histoplasma. And he has a role, and the macrophages have a role in this, because they try to destroy histoplasma. However, the organisms survive and proliferate within their cytoplasm, and eventually the macrophages are ruptured. So another cause of lung pneumonia are fungi and mycobacterial infections, in which the macrophages become activated, should be activated, so as to destroy this factor. So always we should take into account the degree of T-cell mediated immunity. And of course there is a whole, it should be a balanced response having to do with the cytokines that activated lymphocytes secrete. If these cytokines are too many, and you'll have a T helper 2 response with many lymphokines, this is not for good, because this destroys the tissue. T helper 1 lymphocyte production is more efficient. because the main product is interferon gamma. And in this way, the infectious agent can be more properly treated. Now let's have a look at this macroscopic specimen. Of course, we have problem in the lung parenchyma. Can you see which area is affected by consolidation? Is it a restricted area, or is it a very large area within the lung parenchyma that is affected? What do you think? It's very large. So there is the greatest amount of the lung has been affected by consolidation of pneumonia, inflammatory infiltrate within the alveoli. However, what may this be? Here, what anatomic structures are these? They are bronchi. So, have a look at this bronchus here, all right? You see? And have a look at this one, where this is close to, which is this surface. You see this serous membrane here. You see the membrane? Which membrane is this? At the periphery of the lung parenchyma? Pleura. Yes, it's one of the two layers, the one that is in direct contact with the lung parenchyma. So, why is this abnormal? This is a bronchus, like the other one we saw. Why is this abnormal? You'll take into account that we are at the lung's periphery, all right? So, why is this bronchus that you identify in this part of the tumor abnormal? I can see its lumen very nicely. Why is it abnormal? What should bronchi do when they come out of the bronchial tree? It comes from the hilum, when we have the main bronchi, and as we go to the periphery of the lung, what they should become? Should they be visible there at the periphery? No, they should become small. Is this the case here? No. So how is this called? How is this called? Bronchiectasis. Bronchiectasis. That means that's due to, frequently, this is due to repeated episodes of inflammation, purulent inflammation of microbes in the bronchi wall, and it loses its elasticity due to inflammation, so it is permanently dilated. However, in the present case, apart from this ectasia of the bronchi, we have pneumonia as well. This is why this large part of the lung appears consolidated. However, this is a mixed type. We have bronchiectasia and consolidation due to pneumonia. And you see that there was a history of severe recurrent pulmonary infections which affected the integrity of the lung, of the bronchi wall, and caused this macroscopic finding. But the patient had also malabsorption and steatoria. That means there was fat in the stool. So this looks something that affects both the lung and the digestive system. What do you think if there is an increased amount of fat in the fetus? What will you think if you think simple enough? What would be wrong? So that fat is not absorbed in the lumen of the gut, of the small intestine, and you have an increased amount of fat in the stool. What can be wrong? Which organ may be affected? Think simple enough. Yes? The pancreas, because the exocrine portion has the pancreatic fluid, which is responsible, along with what else? The bile for this absorption of fat tissue. Another thought would be an inflammation in the wall of the intestine, which destroys the absorptive area. And another cause would theoretically be a flattening of the villi of the intestine, which will make the area available for absorption too little. You'll discuss all these possibilities in the next chapter, digestive system. But I show you this example here because this is something from the lung. However, as we said that we have an holistic view of medicine, the same process affects other organs of this patient. And can you think what this might be? And he has all these problems, and the mucus in the bronchi is too thick. And if it is too thick, it cannot leave the lung easily. So there is some sort of stasis there, and microbes develop, and they cause the destruction of the bronchi. And look that it is a very young man. If this happens to a very young man, you think that it might be something inherited. What could that be? Which disease? Yes?
Cystic fibrosis.
It's cystic fibrosis. That means an inherited disease affecting both the pancreas, which becomes atrophic, so there is not enough pancreatic fluid so that lipids are absorbed, and they cause steatorrhea. And of course we have other lesions in the bronchi. So, and in this case, the salt from sweat glands tends to be very high, and there are some other deformities as well. And as far as the lung is concerned, in cystic fibrosis, viscous pulmonary secretions are not readily cleared, and so they support the growth of select bacteria, which caused this recurrent inflammatory process in the bronchi wall, which resulted in their dilation and the consolidation of the adjacent lung parenchyma. So bronchiectasis was complicated by pneumonia. And if, here is another case of pathologically dilated peripheral bronchi. However, what has the inflammatory process caused within the border of two lobes? And it could have caused the same things between the two layers of the pleural. The one layer that is in contact with the lung, and the other that it is in the thoracic wall. What are these structures that have formed due to the persistence of the inflammatory infiltrate? What are they? Because we've discussed that when an inflammatory infiltrate reaches such surfaces which are lined by mesothelia, there is a particular type of inflammatory exudate formed. What is this? Which, when the inflammation persists and is not lysed, this is organized, this type of exudate is organized, and you see that the two anatomic structures can no longer move easily. It's not the case here because it's between the two lobes, and the two lobes should not, of course, move. But if this would happen in the pleura, that would cause a problem. It would cause pain to the patient because the lung would not be able to expand in the thoracic cavity. So what is this? What is this complication of the persistent inflammation in this case? Scarring. These are strictures, right? Strictures. And of course, this happens when the inflammatory infiltrate is rich in fibrin, as the case is so in areas of in areas where we have layers with mesothelial lining, such as the pleura, the pericardium, the peritoneum. So inflammation should be treated on time, because if such an inflammatory infiltrate persists, strictures will be formed. So these are strictures. In the present case, we had bronchiectasis and post-inflammatory scarring in the form of these interlobar adhesions. And this is a syndrome, in this case, also inherited as the previous case, Cartaginer syndrome, where there is a problem in the cilia of the respiratory epithelium, because if they are immobilized, they cannot send the foreign particles away, so this can cause inflammation in the bronchi epithelium, which in the present case resulted in bronchiectasis. You see, peripheral bronchi, too dilated, too much dilated, with too much dilated lumen. Now we have a CT with this lesion here. Despite the fact that it is, no, but tell me the features of this lesion here. What would you think it may be, taking into account what we have already discussed? Yes?
So since we see the two lungs filled with air, and
Yeah.
then we see some kind of tissue which has
Without air.
Yes,
So,
without air.
what can this be then? Think, what can this be?
an abscess which is probably
Yes, if it had some air within and it would appear somehow cystic, it could be an abscess. However, it's too solid,
yes, it's an abscess which then formed into a scarring.
which might have been fully, yes. So you remember a part of restrictive lung disease when we have these fibrous nodules that we have discussed in our previous lesson. What could that be? If it was just a nodular accumulation of fibrous tissue, which restrictive lung disease of known etiopathogenesis would be justified in this case? Remember? Not the embolism. The embolism should cause an infarct. The embolism should cause an area of necrotic tissue. This does not appear necrotic. It appears viable tissue. Do you remember? We've discussed. Not obstructive, restrictive. Restrictive. That means that fibrous tissue replaces part of the lung parenchyma. It's not idiopathic pulmonary fibrosis. It's not interstitial pneumonia, but there is one form of restrictive disease, occupational. It has to do with exposure, which could be justified. This is silicosis, all right? What else can this be? If we move from reparatory tissue lesions, it could be a tumor, yes. A tumor could be benign or malignant. Of course, we have quite a smooth margin. This, in the present case, is not so suggestive of a benign lesion. However, it could be. I'm not sure, because a lot of lung cancers radiologically appear with like a coin lesion. That means with a deceptively smooth contour.
Okay.
So all rules have their exceptions. It's not the only way that lung cancer could appear, but it does so sometimes, and quite often, I'd say. And however, there is a possibility that this is a benign lesion, which, however, it would be an accumulation of tissue, but without neoplastic potential. This would be a hamartoma. That means an entrapment, a tumor-like lesion consisted of normal tissues, however, in a wrong place. this would be an hamartomatous lesion. That means it would look like a tumor, but it would just be an entrapment of tissues in a wrong place without any potential to become bigger, to grow. So it would not be a neoplasm. And another possibility is a granuloma. However, if that would be related to either a fungus or tuberculosis, so what is there that we can do so that we can see what it's about? You'll take a biopsy. So you'll have the endoscope from the trachea, go to the bronchi, and you'll have in parallel the picture of the lung, because if you see something in the bronchi lumen, of course, that's where you take the biopsy. But in many cases, the tumors are either below the epithelial lining of the bronchus, so you have to cut the bronchus and have a transbronchial biopsy and take representative material of the lesion. And in some cases, they are too peripherally so that the endoscope cannot reach the tumor. Is there another method of checking, of examining cells from these tumors if they are too peripherally located so the bronchoscope cannot reach them, either directly or by cutting the bronchus? Is there another possibility that we take cells from these tumors? Of course. Yes? The fine needle under CT guidance, where a needle will enter from the outside of the patient. And there is another possibility as well when we have the bronchoscopy, is you reach the point where the bronchoscope can, and then you send fluid. And you take the fluid back, and it has had some cells from the suspicious lesion, and then what will you do to examine these cells? It's not a tissue, it's not a biopsy, because it's the fluid that you reabsorb when you send the fluid and take it back. What would that be? It would be and look it in the microscope after centrifugation. What's that? Centrifugation. You take the fluid, you centrifugate it, and then you take what is left and make a slide. Make a slide and put it in the microscope. This is a cytological smear, because these are exfoliated cells from the lesion. And if you see malignant cell, you say it's positive. In case it would be tuberculosis, which kind of cells should predominate? If that was a granuloma of tuberculosis, which type of cells would you find in the cytological smear under the microscope? If that would be a granuloma, either of sarcoidosis or tuberculosis, which cells would predominate? Since both of these granulomas are immune granulomas, as we have discussed. Which cells should predominate if we have an immune granulomatous chronic inflammatory disease? Yes? No, the lymphocytes, no. It's not the most characteristic cell. They belong to the immune granulomas. Lymphocytes belong to the immune granulomas. However, they do not predominate. They are located most common on the periphery of the granulomas. Yes, you could see lymphocytes. However, they would not be too characteristic for an immune granuloma disease. Other cells, which are the cells which make the granulomas, make these nodular accumulations of inflammatory cells. Which cells are these? The epithelioid cells. They were, some time ago, they were macrophages. However, due to the immune response after specific recognition of the inflammatory agent by the immune system. The immune system has CD4 T cells, has secreted cytokines, and what did they tell the macrophage? Don't phagocytose any longer. Become exclusively secreting cells. And this is the epithelioid transformation of macrophage. And the cytokines secreted by the CD4 cells after this specific type of recognition of an inflammatory agent told the macrophage, stay there. Don't leave, don't be dispersed in the tissue, stay there and form a nodular structure. So this would be an immune granuloma mainly composed by epithelioid histiocytes, macrophages some time ago, and T lymphocytes, and you can see some multinucleated giant cells as well, which are accumulated macrophages. And if it's tuberculosis, there is an extra finding which you can possibly detect. Either the giant cell have like a horseshoe accumulation of the nuclei, so they are identified as Langhans giant cells. And what else is common in tuberculosis granulomas? Epithelioid macrophage, foreign body, multinucleated giant cells, mainly of the Langhans type, not exclusively, mainly of the Langhans type. And there is another finding as well, which could justify a cavitation of the lesion. When you see a cavitated lesion, remember the abscess. It had liquefactive necrosis. Which other lesions can cause this cavitation? And you can see that the center of the lesions becomes necrotic. One is the abscess due to bacteria. Other lesions, a tumor, which could become necrotic because tumor cells need to grow and their neovascularization may not be enough for their growth, so they become necrotic. And the other is an immune granuloma of tuberculosis, because most, not all, but most immune granulomas of tuberculosis show a particular type of necrosis, which could justify the cavitation of this lesion. And which type of necrosis is this? Caseous necrosis. So these three types of lesions can show cavitation in the lung. Tuberculosis with caseous necrosis, abscess with liquefactive necrosis, pus in other words, and tumors which become necrotic due to their increased potential for growth that makes their neovascularization insufficient. So in our last lesson on lung, we'll deal with the most fatal cancer, taking into account its incidence, which is lung cancer. So that's what we'll do on Wednesday. Bye-bye now.